This video primarily focuses on pancreatitis, which makes up the majority of benign pancreatic disease. Pancreatitis can either be acute or chronic, and we will look at each of these in turn. Acute pancreatitis refers to inflammation of the pancreas without any permanent destruction to gland function. There are numerous causes of acute pancreatitis, which can be easily remembered by the mnemonic "get smashed." The first two letters stand for the two most common causes of acute pancreatitis, and thus are the most important ones to remember. They are gallstones and ethanol, or alcohol. After this, other causes are trauma, steroid use, mumps, autoimmune disease, scorpion venom, although this is rare, hypercalcemia or hypertriglyceridemia, ERCP, and drugs, specifically including NSAIDs, diuretics, or azathioprine. With regards to pathogenesis of acute pancreatitis, the cascade of events begins with premature activation of pancreatic enzymes within the pancreas. This leads to inflammation of the pancreas and an inflammatory cascade. The inflammatory cascade leads to increased vascular permeability and third spacing of fluid into the peritoneal cavity. It also allows for the release of enzymes into the systemic circulation. Within the pancreas itself and elsewhere in the body, the enzymes digest adipose tissue and lead to fat necrosis. This results in the release of free fatty acids, which readily bind to calcium ions, hence reducing the level of free calcium, resulting in hypocalcemia. With regards to signs and symptoms, the patient will classically have sharp epigastric pain that radiates around to the back, an associated fever, associated nausea and/or vomiting, tachycardia, potentially a rigid and guarded abdomen, and hypotension due to third spacing of fluid. Although it is now rare, associated retroperitoneal hemorrhage could also lead to bruising around the umbilicus, also known as Cullen's sign, and/or around the flanks, also known as Gray-Turner's sign. This is a late-stage complication and the patient should be treated before it gets to this point. The patient may also present with jaundice if they have associated biliary disease. Generally, the investigations for acute pancreatitis can be split into both laboratory investigations and imaging investigations. Laboratory investigations include routine bloods for an acute abdomen, including a full blood count, U's and E's and CRP, serum amylase, which in pancreatitis should be 3 times the upper limit of normal, serum lipase, which should also be raised and is often more sensitive due to its levels being elevated for longer than serum amylase, and liver function tests to see if there is any associated liver or biliary pathology. The imaging done often includes abdominal ultrasound scan, which is particularly useful if concurrent gallstone disease is anticipated, an abdominal X-ray, which is not routinely done, but certain signs on an abdominal X-ray can be suggestive of pancreatitis. Examples include that of a sentinel loop sign, which is a short segment of adynamic bowel in close proximity to the pancreas. Sentinel loop sign generally is an indication of an intra-abdominal inflammatory process, and they can also be seen in appendicitis. A chest X-ray may also be done to check for complications such as pleural effusion or acute respiratory distress syndrome, which are associated with pancreatitis. Finally, CT scans can be done. Again, these are not routinely undertaken in the first instance. This is because clinical scoring has been shown to be just as or more valuable as scoring severity from CT scans. Based on clinical examination and basic investigations, the severity of acute pancreatitis can be scored. This is done via the modified Glasgow criteria. There are 8 parameters that are analysed, which can be conveniently presented in the mnemonic pancreas. P stands for PO2, with 1 point occurring if it is less than 8 kilopascals. Age, for which they score 1 point for being greater than 55 years old. Neutrophil count, for which they score a point if the cell count is greater than 15. C stands for calcium, for which a point is gained if there's a concentration of less than 2 millimoles per litre. Renal function, specifically serum urea, with 1 point if it is greater than 16 millimoles per litre. Enzymes, more specifically lactate dehydrogenase or aspartate transaminase, with 1 point for either an LDH of over 600 units per litre or an AST of greater than 200 units per litre. The second A is for albumin, in which 1 point is scored if it is less than 32 grams per litre. And finally, S stands for sugar, i.e. blood glucose, with 1 point if the value is over 10 millimoles per litre. Any patient scoring equal to or greater than 3 within the first 48 hours should be considered to have severe pancreatitis, and referral to HDU is warranted. Now we'll look at treatment. There are no direct specific treatments for acute pancreatitis, so the majority of initial treatment is supportive. This includes high-flow oxygen, IV fluid resuscitation, wide-bore nasogastric tube if vomiting to decompress the stomach, catheterization to monitor fluid balance, and appropriate analgesia via the Hu ladder. Definitive treatment involves addressing the underlying cause of the pancreatitis, such as a laparoscopic cholecystectomy for gallstone disease, referral to alcohol services for any alcohol dependency, or antibiotics if there is any associated necrosis or infection. There are many possible complications of acute pancreatitis, which can generally be split into either systemic or local complications. Systemic complications include disseminated intravascular coagulation from an overwhelming inflammatory response, acute respiratory distress syndrome, hypocalcemia due to sequestering of calcium ions by free fatty acids, and hyperglycemia due to lack of functional pancreatic tissue. Local complications include pancreatic necrosis, which can occur if there is ongoing inflammation leading to tissue necrosis. This is most typical around 7 to 10 days after initial onset of symptoms. The necrosis can be picked up on a CT scan, and it is often treated via pancreatic necrosectomy. And it is particularly prone to infection, hence antibiotics should be started when necrosis is suspected or found. Another local complication is the formation of pancreatic pseudocysts. These are a collection of fluid that contains pancreatic enzymes, necrotic tissue, and blood. They can occur within or adjacent to the pancreas, but most commonly they protrude forwards into the lesser sac. It doesn't have an epithelial lining, hence it is termed a pseudocyst. Instead, it is surrounded by fibrotic tissue and blood vessels. They can be asymptomatic and found incidentally, but some people will present with symptoms of mass effect as it compresses on surrounding structures, an example of which would be compression of the stomach and early satiety. 50% of cases spontaneously resolve and hence don't need definitive management. However, a proportion will need surgical debridement and drainage. Now moving on to chronic pancreatitis. It is a chronic inflammatory disease of the pancreas that leads to irreversible damage to the gland and reduced function. The average age of onset is around 40 years old. Some of the causes of chronic pancreatitis are similar to that of acute pancreatitis, in particularly alcohol consumption being the most common cause of chronic pancreatitis at 60%. 30% of chronic pancreatitis cases are idiopathic in nature. Other notable causes include metabolic disturbances, such as hypercalcemia or hyperlipidemia, infective causes, hereditary causes such as cystic fibrosis, autoimmune causes such as autoimmune pancreatitis or SLE, any obstructions of the duct, either due to cancer or stricture formation, or any particular congenital causes such as pancreas divisum, in which there are 2 pancreatic ducts, or an annular pancreas, in which part of the pancreas is wrapped around D2. With regards to the pathophysiology, chronic pancreatitis can be split into either large duct disease or small duct disease. Large duct disease is more common in males. It is easier to diagnose due to the ducts being visible on imaging, as well as there often being calcification in the pancreas and stone formation. Whereas small duct disease is a lot more subtle. It's hard to see the ducts on imaging, and there's rarely any calcification or stone formation. Hence, it is difficult to diagnose. And it is also more common in females. The most prominent symptom in chronic pancreatitis is actually chronic pain. Similarly to acute pancreatitis, the pain is often in the epigastrium with radiation moving round to the back, and this may be eased on leaning forward. There may also be some associated nausea and/or vomiting, and on examination there may also be a palpable abdominal mass, for example if there is an underlying neoplasm or a pseudocyst formation. Differently from acute pancreatitis, as there is irreversible destruction of pancreatic tissue, patients will have symptoms secondary to gland dysfunction. These include symptoms associated with either endocrine complications, such as polydipsia and polyuria in diabetes, or those associated with exocrine complications, such as malabsorption and steatorrhea due to impairment of fat digestion. Again, after clinical examination, investigations typically done for suspected chronic pancreatitis can be split into laboratory investigations and imaging investigations. For laboratory investigations, these again include routine bloods that would be done for an acute abdomen, including an FBC, U's&E's, LFTs, and serum amylase. Due to potential endocrine dysfunction, a capillary blood glucose, or BM, is then done, as well as a serum calcium, with raised calcium being one of the causative factors for chronic pancreatitis, as well as low calcium resulting from attacks of acute pancreatitis. Finally, the fecal elastase level can be measured and is often low in chronic pancreatitis. It is an enzyme that is made by normal pancreatic tissue, and hence it is low in chronic pancreatitis as there is damage to gland function. Differently to acute pancreatitis, serum amylase and lipase are very rarely raised in cases of chronic pancreatitis. With regards to imaging, ultrasound and CT abdopelvis can highlight other intra-abdominal pathology, with CT scans also showing any calcification and stone formation. MRCP is good for assessing the pancreatic duct, as well as any concurrent biliary disease. It is still unlikely to pick up ductal changes in small duct disease. And finally, ERCP, which has the ability to combine diagnosis with intervention. In both ERCP and MRCP, IV secretin can be given. This stimulates the pancreas to produce a bicarbonate-rich fluid, which then travels through the ducts, hence further highlighting any abnormalities, such as strictures. With regards to treatment, the three main areas to address when treating chronic pancreatitis are avoidance or treatment where possible of the precipitating factor, adequate analgesia for chronic pain, and nutritional support, which can be given in the form of enzyme supplements such as Creon. In a select few patients, endoscopic or surgical management may be warranted. Some endoscopic approaches used are ERCP for stone extraction, endoscopic ultrasound in order to drain any cysts or for stent implantation, or endoscopic pancreatic sphincterotomy, which can be done if there is stenosis around the sphincter of Oddi. Endoscopic procedures should be used sparingly, as they can precipitate acute on chronic pancreatitis. In some instances, surgical treatment can be undertaken. This mainly occurs when an obstructing mass or lesion needs to be removed, and approaches will vary. For patients with an autoimmune cause, steroids are an effective treatment. Looking now at complications and general prognosis, alongside the previously mentioned endocrine and exocrine complications, the malabsorption results in a decrease in the fat-soluble vitamins A, D, E, and K. Therefore, blood clotting needs to be monitored, as well as bone density. Pancreatitis is also associated with fluid accumulation, which can occur in the form of ascites or pleural effusion, both of which would have a high amylase concentration. Another important complication of chronic pancreatitis is pancreatic malignancy. In general, the quality of life in these patients is poor, and 1/3 of patients with chronic pancreatitis will die within 10 years. In this video, we have covered the basics of chronic pancreatitis, including causes, an overview of the pathophysiology, such as large duct and small duct disease, and the different features of both, the common symptoms and signs of chronic pancreatitis, and what these symptoms relate to in terms of gland dysfunction, the classic investigations done in a case of suspected chronic pancreatitis, including laboratory tests and imaging, as well as what you'd be expected to find in each of these tests, an overview of the treatment of chronic pancreatitis, including the three main points, as well as endoscopic or surgical treatment for selected cases, and other associated complications as well as general prognosis. We have also looked at the basics of acute pancreatitis, including the causes, which can be remembered by the mnemonic get smashed, the pathogenesis and the sequence of events that occurs, the general signs and symptoms, ranging from very common to now rare, the common investigations done, including laboratory investigations and imaging investigations, and what you'd expect to see on each of these, risk scoring criteria for acute pancreatitis, such as the modified Glasgow criteria, along with the values for each parameter, an overview of the basic treatment used in acute pancreatitis, which is largely based around supportive treatment, as well as treating the underlying cause, and an overview of some of the complications associated with acute pancreatitis, including systemic complications and local complications, such as pancreatic necrosis and pancreatic pseudocyst formation.